that's fine.
So we'll give it about 5 more minutes. So how long ago was this study?
The study took years to complete, but it came out 3 months ago.
Oh, okay, wonderful.
Yeah.
There's already a lot of articles written about it.
Yeah, we've been getting you know, a lot of interest from colleagues, from patients, from their families. It was mentioned in various you know, news venues. The Economist had an article about it, so then we got sort of bombarded with requests for testing from all over the world, actually. And I'll tell you a little bit what we did about that.
Okay. And you are originally from Romania?
Yep, I was born in Bucharest, Romania, and then in my early 20s came to the US for graduate school. Then I did my
I'm listening
clinical
to you.
training.
Thank you.
Can you guys hear
You
me?
doing all right?
Yeah, doing good.
Yeah.
Okay.
My grandmother emigrated from Romania to Turkey back in the 30s. So I'm a little bit Romanian. All right. So I'm going to mute all the members for this talk, except for Dr. Niculescu. I accidentally muted you. There we go.
I unmuted myself.
Okay.
I cannot be silent.
So La Jolla
Right.
is a wonderful
Let me know
place.
when I should start. We have until we have an hour, right? A bit less than an hour. So I sort of budgeted that you know, so we start around 4 p.m. California time, finish around 5 p.m. California time. Is that correct?
Okay, let's start now then.
Okay. So let me share my screen. You disabled my screen sharing, so do you want to enable that?
Okay, there we go. It should be able to share now.
Okay, all right. So let me pull up the correct presentation. All right, do you guys see my screen?
Yes.
Yes, everybody sees it? Okay. All right. So the story I'm going to tell you today actually was prompted by that recent study that came out about sort of state-of-the-art precision medicine approaches to mood disorders, to depression, to bipolar disorder. But this journey really started 2 decades ago. And I wanted to give you a little bit of background about how we came about to do this. And then I'll discuss that study, and then I'll end with some sort of practical applications and thoughts about the future. So that's why I sort of made this a little bit more broad. And our mission has always been to bring precision medicine to psychiatry, which is a field that has lagged a little bit behind other fields of medicine. So it takes 20 years to become an overnight success, basically. So I'm currently a professor at Indiana University School of Medicine. And my disclosure is I'm also the founder of a biotech startup called MindX Sciences. Those are the 2 websites for my academic group and for my company teams. And if you don't remember anything from what I'll be telling you today, or have additional sort of questions, or you can just go to those websites, and we put a lot of our materials, papers, all sorts of nice information over there to try to be as helpful as possible to the community. So when we started this work, we we were, at that time I was in California at the University of California, San Diego, where I did my clinical training and had my first research lab. And at that time, we realized that in order to make progress in understanding mental health disorders, you have to take a very comprehensive approach. You do human studies, but you also do animal model studies, and you try to integrate them. There are certainly things that we can do in human studies that are unique to, and in the end, that's sort of the goal of the whole exercise, is trying to understand the human mind, understand when it's disrupted, and how to fix and improve that. On the other hand, there are things that cannot ethically be done in human studies. So for that, we've used all sorts of animal model studies with sort of appropriate and ethical safeguards and so on. About 15 years ago, we've put together this very simple, model for psychiatry. I call it, psychiatry for dummies, and in that category, I include myself, where we basically, propose that there are these three broad domains: the anxiety domain, the mood domain, and the cognitive domain. That stress is a major trigger of psychiatric disorders, and that there's overlap among them, these domains, and there's a lot of diversity inside them. So this is sort of if you look at this cartoon versus how the DSM is, or the ICD-10, the sort of diagnostic telephone books by which psychiatrists go to sort of diagnose and bill and for patients. It's a much simpler and much more condensed view. And then over the last 20 years, we set about to map the genomic landscape of this disorder. So these are all studies from my group, where we've done work on mood disorders, bipolar disorder, depression. We've done work on anxiety disorders, on schizophrenia, on alcoholism, stress, and so on. Most recently, we've done a lot of work on suicide, which is an unfortunate outcome of a lot of these mental health challenges and so on. So we've mapped the territory along with other teams in the field. And the reason we were able to do that was that when I was recruited to Indiana University from UC San Diego in 2004, we set about to build this sort of cohort of patients that we follow over many years. We have them come to be tested in our research setting often. We also go and test them in their clinics when they get hospitalized. And we were able to follow them over time and see what happens to them when they are sick and when they're doing well, and track their symptoms, their biochemical changes, including these changes in the blood that we call biomarkers. We've also done a lot of work in terms of assessing their symptoms and their disease in a more quantitative way. So we pioneered early on the development of more quantitative type of questionnaires and instruments, of apps, and so on. And now sort of that's become sort of very routine and the coin of the realm. So really, the ability to follow people over time, test them and get insight from them and look at the outcomes was what made a lot of this possible. As I said, I'm a psychiatrist and a geneticist, so, still see patients, do a lot of human studies. We also do a lot of sort of basic research studies in animal models where we test various compounds that may be useful or may mimic aspects of psychiatric disorders. We do genetic studies in different animal models and so on. So some of the things that some of our quote unquote secrets or innovations that made some of our success possible was, first of all, we learned from cancer. So as you might know, in cancer, precision medicine is already a fact, right? So when you get diagnosed with a cancer, hopefully that doesn't happen, but it's 1 in 3 people will get a cancer diagnosis in their lifetime. When you get diagnosed with a cancer, you don't just sort of get a label. You have this type of cancer. You get the molecular profiling so that you can get matched with the right medication and so on. My background is actually in cancer molecular genetics, my research background. So my graduate work at Scripps was on cancer molecular genetics. So when I moved over to brain science, so brain health and psychiatry, we brought a lot of those insights and technology into the study of psychiatry. And I'll mention a little bit how each of these insights helped us with our work along the way, helped us to do, to make the most out of the, the contributions that our patients were making to our studies, and how some of that is filtering into actual current clinical care. Second thing was convergence. You don't, we don't study things in isolation, just do genetic studies or just do animal model studies or just look at symptoms or just look at blood molecular changes. We put everything together, and when there's convergence and things come together, that's when you have more confidence that you found something real. The third thing is what we call phenomics. We are very quantitative and precise about how people feel, think, and behave. We measure that, as opposed to saying, well, you have depression, or you have bipolar, or you have PTSD, and so on. Those are very broad labels. We actually measure how people feel, think, and then are able to track that. So we call that phenomics. It's a term that's similar to genomics, where you study DNA, the genome. Phenomics is you study their phenomenology, so to speak, their feelings, thoughts, behaviors. The fourth thing is that we were very translational, as I mentioned. We went from bench to bedside and so on. We integrated things, and we brought together very different approaches to try to understand and do a better job for our patients. The fifth thing is we've developed this very careful 4-step approach to discovering this sort of molecules in the blood that were now used for testing in clinical settings. So you have to be very careful about, making sure that you found something that's reproducible, that you know how useful they are, how accurate, and so on, before you publish, before you start offering them as part of clinical practice. And then the sixth thing is these 3 circles. As this company that I founded is based on this idea that you have to start first. The outer circle is with an accurate assessment of somebody. We do that through digital means, through apps and so on. Then that brings people to the middle circle, which is molecular testing, and then that brings people to the inner circle, which is the right therapy or the right combination of therapies that fit that particular person, their profile. So this is, our convergent approach. This is very technical. The basic idea is that, a lot of arrows are used to point to a particular gene or biomarker. So we use a lot of different approaches to find and validate something. That's the convergence. In the past, even in the recent past, there has been a lot of debate in the field whether, why is it so hard to find genes or mutations for psychiatric disorders? And here at the bottom, that little red thing is sort of the reproducibility that people have between DNA type studies when they look at letter in your DNA between different studies. And it's abysmal, it's very small. But the reason is, that actually people should not be looking at letters in DNA, should be looking at whole chunks of DNA, whole genes that are the ones that are actually active and participate in the disorder. So when you start doing that and then look at sort of groups of genes involved in the disease and so on, you get much more overlap and reproducibility between studies. So we think that people have mostly been looking sort of at the wrong end of things, and our work is at this other end, and we see a lot of consistency in our work, in other people's work, and so on. And in the end, biology happens when genes are expressed, make proteins, work together in cells, in the body, and so on, not just isolated letters of DNA. That's sort of another way to depict that. Now, the third sort of innovation here, the phenomics part, this is interesting. I'll show a couple of slides here. So this is just a quantitative way of looking at behaviors, okay? So that's all it is. And this sort of colorful slide here shows actually my clinic population in 2006, or at least the part of my clinic population that had signed informed consent and volunteered for our research studies. And the point that I want to make here is that when you look at the bottom, when you have those things that look sort of like military, war ribbons or whatever, you can see that those colors stand for normal controls, bipolar, schizophrenia, schizoaffective. There's a lot of overlap and interspread between them. There's not sort of a group of patients that's cleanly bipolar, that's cleanly schizophrenia, cleanly schizoaffective, cleanly normal controls, and so on. A lot of overlap and interplay between them. So this profiling here in this study, we've looked at battery of 25 different measures that measure mood, anxiety, and so on. When you profile people in a very thorough way, you start to see that each person, there are a lot of people that are, a little bit different and unique in a population, and that treating everybody the same way, one size does not fit all. And so nowadays, well, a decade ago, we actually thought it's even better if you just treat people in a dimensional way, and that was before the National Institute of Health and so on started saying, well, we should be more dimensional in how we diagnose people. But basically, each and every one of you could be, could get a measure for their anxiety, for their mood, for their cognition. And these XYZ coordinates that point, in time with these XYZ coordinates in this three-dimensional space would be where you're at this point. Then if you're measured again tomorrow or in a week or in a month, you might be here or here or here. And then that cloud over time is who you are, uniquely so. As opposed to saying, well, you have a mood disorder and we just try to cram you on this dimension here, on this axis, or you have an anxiety disorder here and so on. So most people actually are three-dimensional in terms of their symptoms, how they behave, and so on. That's why a lot of psychiatrists in clinical practice, a lot of my colleagues end up sort of having multiple diagnoses for a patient. They have, bipolar 2, PTSD, anxiety disorder, NOS, etc. 3-4 labels. When it's the same, it's just one person. It can't be 3-4 labels. That person is somewhere in this space, and they have some anxiety symptoms, some mood symptoms, some cognitive symptoms. It's a better way to look at it. And since we've done that, we've actually started to. We proposed that a decade ago, and now we have the tools to actually measure anxiety, mood, cognition, quantitatively with apps, with blood tests. So now we can, offer that to patients. So this is a study that hasn't been published yet where we've done that. So, you can see people with various diagnostic, DSM diagnostic label, bipolar, schizophrenia, schizoaffective in my clinic who volunteered to participate in research. And you can see how all over the place and interspread they are. They're not sort of distinct groups. So each person is, you can also follow people over time. So these are, the red patient is a bipolar patient at 3 visits, and you can see how they move in this space. The green is a schizophrenia patient, blue schizoaffective patient. So bottom line is we're developing now some ways of visualizing this where on a phone, you could see, where am I today in this mental landscape, mindscape, and you could see over time how your cloud evolves when you're doing well, when you're not doing so well in response to a treatment. And that cloud there is a very personalized way of who you are, as opposed to just having a label, DSM label, and so on, that is imprecise and leads to confusion and adverse treatments. So don't worry, we'll soon have you all sorted out using this approach. This is a cartoon from the New Yorker. All right. So this work, you know, as you can imagine, has been a sort of a gigantic effort over the years. We've tested close to 1,000 people with many years of follow-up with a lot of high-tech tools and so on. You know, all this sort of work went into it. The practical application that we've developed and that I'll talk about today is sort of the ability to use blood testing as a way of getting some handle on the severity of the disorder, of what medications might work in a patient and so on. And that's very important because, you know, for obvious reasons, we can't biopsy the brain in humans, right? In live humans, in psychiatric patients, although there's some sort of high-tech entrepreneurs who are thinking about doing that, or at least planting electrodes and things like that. But that's not yet here, and it's very sort of ethically fraught. So if you could find something that's simple in a blood test, when you go for your annual exam or your regular appointment, you get your blood drawn for whatever, for lithium level or for your primary care appointments, then you can also look at the markers and see how well you're doing in terms of your mental health and whether you're responding or not to a treatment. Then, you know, that's something simple and useful. So that's what we went for. And took us many years to develop the approach, validate it, test it, and so on. But we're there, we're here now with it. And these so-called blood molecular markers or biomarkers, we think are helpful in helping doctors with diagnosis, in terms of helping them with medication choices, in terms of helping pharmaceutical companies with clinical trials so they don't fail so often as they do, and in terms of really for us in academia, in terms of understanding the disorder. And these are some technical things about what sort of population sizes you need. I won't bore you with that. So mood disorders, which is sort of the topic of interest, we actually did our first blood test work in mood disorders over a decade ago. And at that time, it was extremely sort of going out on a limb and novel. At that time, which was over a decade ago, we found a panel of 10 molecules in the blood that were predictive of mood state. And, you know, it was a very exotic thing when we published it. And this panel of 10 markers was about 70 to 80% accurate in classifying low mood, high mood, etc. So we were a bit ahead of our time at then. 2-3 years after our study, a group in Europe, in Hungary actually, independent of us, we didn't even know about them, took our panel of 10 markers and reproduced our work and actually got even better results than we did. They looked at response to cognitive behavioral therapy, which is one of the sort of standard psychotherapy approaches that we use in mood disorder patients. And they showed that, before CBT, this was the mood biomarker score, low, depressed, for patients with depression. After CBT, it improved. And then in normal controls who didn't have depression, it was a little bit higher. So you can see this sort of very nice tracking of mood with this very simple panel of 10 markers. So that was sort of the breakthrough that convinced us that we can, with our careful, sophisticated approach, find something. And then for the last decade, we've sort of doubled down on the work, expanded it, and seen how can we bring it to, to a place where actually I can use it in my clinic, other doctors can use it, and it can actually benefit patients, as opposed to just publishing studies, getting sort of people excited, and then how do they benefit from it? Can they get tested? Does it affect their care or not? So, so nowadays, the way we discover these blood markers is actually very, very sophisticated, very OCD. These 4 steps, we do a discovery type approach. I won't bore you with the details, but it's very elaborate over time, over years. Then we prioritize them using a Google-like sort of algorithm, looking at all the literature in the field, our own data. Then we go into independent cohorts and of very ill patients and see, can we validate them? Are they even more changed in the very sick people? Then we go in additional cohorts, clinical cohorts, and see are these markers useful clinically to assess who's sick, to assess who will have future clinical or worsening, and so on. So we've done that. The term of the art for that is liquid biopsies. It comes from cancer. So we've developed this sort of liquid biopsies for different mental health conditions, not just mood disorders, but also suicide risk, pain, PTSD, memory, Alzheimer's, and longevity. And the work that I was invited to speak about today briefly is this sort of second generation mood disorder panel. Came out 3 months ago in molecular psychiatry, which is a high impact specialty journal in our field. And got a lot of attention from colleagues, also from the lay media. As I mentioned, it was mentioned The Economist, various sort of other newspapers, TV, radio, etc. So we were then deluged with requests for testing, which prompted us to try to expand and accelerate that startup that we put in place so that we can accommodate clinicians who want to order it for their patients. So basically, what the study did was three things. It described the development and validation of these blood molecular markers for depression and for bipolar disorder. On the understanding side of things, it uncovered the fact that at a molecular level, mood disorders are driven by so-called circadian clock gene mechanisms, those things that regulate your body level of activity, day and night, seasonal. That's why patients who have mood disorders that are not well controlled have sleep abnormalities. When they're depressed, they sleep too much. When they're manic, they don't sleep. There are seasonal changes where people become more depressed, maybe in winter, become more hypomanic or manic in spring and summer. See that all the time in my patients and so on. And that, now we uncovered the biology of that. And then, so what I have to say is that this sort of interest in circadian clock mechanism has been around for a couple of decades. In fact, early studies that my lab has done 2 decades ago had identified one of the first clock genes. But the interesting part was we came around full circle. The study that we did now to discover these molecular markers was without any hypothesis. We started with all the genes in the genome. We just went, through our careful approach to see which are the best markers that track mood, that predict mood, and so on. So it was not any hypothesis behind it, and it was interesting that we ended up with these circadian clock genes. Then the third major finding or practical application was that it provides a way to objectively assess patients and match them with existing psychiatric medications. So as a psychiatrist, I have all these different choices of mood stabilizers, antidepressants, maybe some antipsychotics, some medication for anxiety. Which one should I use in a patient? So I can do that based on my clinical experience, on other factors related to effects, side effects, but having, in addition, a report that says, well, this patient's molecular profile indicates that, they mostly benefit from this, and that in disorder, it's very helpful. And as I mentioned, this is being done in cancer now all the time. So this is sort of our very comprehensive approach. I won't sort of bore you with it. Besides the clock genes, another sort of striking finding was that one of this thing over here that's called SLC6A4, it's actually the serotonin transporter, a very famous gene in the field of psychiatry. That's the target of all the SSRIs, right? So we found, again, without looking for it, there wasn't a hypothesis that it might be, but we found there was change in the blood, was one of the main markers, and it was changed, in a stepwise way from low mood to high mood. So what this transporter does, it regulates the levels of serotonin, and you have too much of it in depression, and it mops up the serotonin. So then you're more vulnerable to stress, as a consequence to depression. You have too little of it in high mood, so then there's too much serotonin around, and so on. So it goes from low to high. It's like almost like a continuum, like a thermostat for mood. This is very interesting and very important because it's the target, as I mentioned, of all the SSRIs, which are highly, highly used, sometimes excessively used, and not all patients do well on them. So could this be a clue that, the fact that this molecule swings from low mood to high mood, should that be a cautionary sort of clue to us about whether we should be using SSRIs in bipolar? So I'll mention a little bit about that later. So anyway, this is just sort of the boring, careful scientific process where once you find markers, you see how predictive they are. These sort of skyscrapers or buildings over here show, the higher, the more strong the results of biomarkers. So an interesting aspect of it is that biomarkers work much better in women than in men, and are much more predictive in women than in men. So good for women, actually, And we think there are maybe two reasons for that. One is that women are more in touch with their feelings or reporting more accurately. So when we develop the biomarkers, the initial steps, we have to rely on the patient's self-report of how sick they are when we sort of try to correlate changes in the blood. And maybe men are not as accurate as the reporting those things as women are. So women have more insight and share things more readily. The second explanation is that these markers are related to immune system activation. A lot of them, they are markers in immune cells. And the immune system is much more active in women. In fact, women have two X chromosomes, and a lot of the immune molecules are on X chromosomes, which maybe another reason why they are protected against infectious disorders more than men, including COVID, and also on the flip side, they get more autoimmune disease. But this is good news for biomarkers. They are sort of much more, the biomarkers in women are much more predictive, much stronger signal, much more predictive than in men. So this is an example looking at these GLO1, SLC6A4, and so on. These are gene names for the top biomarkers. And you can see how we can see some of them are targets of omega-3 fatty acids, which is very interesting. All my patients are on them along with medication. Some are targets of antidepressants, some lithium, other more medications, and so on. And here's a sort of a key take-home message that this SLC6A4, the serotonin transporter, is changed in depression, in bipolar, in mania, opposite direction in depression and mania. So in a bipolar patient, we think if you use an SSRI monotherapy when they are depressed, you can flip them into hypomania or mania or mixed states. This is why they should be used very carefully in bipolar patients. They could be used maybe in milder forms of bipolar along with a mood stabilizer, but not in monotherapy. And they could be potentially used in depression, stress disorders that don't have the sort of bipolar mania component. In addition to that, we identified other potential medications that are not used in psychiatry currently, but could be repurposed to be used for mood disorders. Some of them are natural substances. A lot of people don't necessarily want to take just medications. So there's a lot of rich material in this paper. And this is how a prototype report would look for a doctor. Now, at the startup side, the reports are much nicer and detailed because there they have already started to be rolled out for clinical practice. But this was on the academic side in the publication. So it's basically like a credit score, financial credit score. You get a score for the severity of your depression, get some indication about your risk for future depression, about switching. You get the list of the medications ranked by fit to you. So in this particular patient, this lady was clinical diagnosis was major depressive disorder, but our blood test indicated that she actually had a high risk for bipolar disorder. So probably she was bipolar, not just depression. And her list of matching psychiatric medications, fish oil was very high omega-3, but lithium was the sort of top match of existing psychiatric medications. and other medications much lower. So, so then you can sort of make a recommendation for her doctor to consider this and that, and use their clinical judgment to use the medications. Now, this case over here that I'm presenting was a tragic case. She had this lady has been part of our studies, and a year after she left our studies, these studies that remember go over many years, she had we heard that she ended up committing suicide. So these studies are done confidential, anonymized. We don't know who the participants are. They all get the code and so on. But when after we heard that she committed suicide, we actually went in, pulled her research records, and wanted to see if there was any inkling there. And as I mentioned, we've also done studies on suicide and looked at blood biomarkers for suicide risk and so on. And turned out that this poor lady was actually at the 100 percentile of suicide risk. That's her over here, very high risk for suicide. And the information was there all along in the research data that we had accumulated, but it was anonymized. It was part of a cohort. That's how you do things in research, confidential. In academia, you don't talk to doctors saying, what the result of the testing was. So that was one of the main reasons that prompted me to roll my sleeves and help found that startup company, Mindex Sciences, so that we have a way of offering this test where we can communicate back to the doctor that's treating these people for the doctor to be aware and have closer follow-up, maybe consider different medications and so on. And we've looked at her blood profile for the mood study, and this is what we saw there, right? That she was labeled clinically with MDD, but in fact she was bipolar, that she should not have been on an SSRI, that she should have been on lithium, which is one of the best medications to prevent suicide, or clozapine, which is also a good medication to prevent suicide. Some data on preventing suicide. So hindsight is always 20/20. The tragedy was that the data was there all along in our research studies, but there was no mechanism to communicate to her doctors. And now we have the company that I helped start. So mood disorders, widespread, very common, very disruptive, but with previous tools, with current tools, I think we can do a much better job of helping people have normal, productive lives, even super normal life. Churchill was famously bipolar, and he lived to over 90 years old and didn't do too badly in terms of his contributions to society. So there's hope. We've also studied a lot of the other sort of risk factors for suicide. That's sort of for another day, those stories. We developed blood tests for pain, for PTSD, for suicide risk, and now for mood disorders. These are the three main factors of the three main risk factors for suicide. And in the end, we want to move from preventing suicide to helping people do well with their current mental health challenges, and then, move towards normal life and productive life and longer lives, basically. So that's what we're doing on a practical sense at the startup Mindex Sciences with our digital tests, molecular tests, and targeted therapeutics. We have now products available, which is very important, meaning you can actually, if a doctor wants to use them, they can contact the company, be enrolled in an early access program, and start testing some of these things with their patients. There's an app that's in the app stores, both Apple and Google, where you can actually, it's like a Fitbit for your emotions. You can track your mood at home, many things, your life satisfaction, stress levels, etc. It's confidential. It all stays on your phone. We don't collect anything at the company. You can communicate or show it to your clinician, your therapist. So it's a Fitbit for your mind. We've developed this other tool called SX Prevent. That's a suicide risk calculator that gives you a personalized treatment plan. With the clinician, a personalized treatment plan. We have our blood test for the various indications, matching with medications, and we provide these dashboards for doctors where they can integrate these results, quantitative results in their patients. So, and we do that now for doctors. The consumers, the patients can use the apps. The blood tests are prescription only, so a clinician has to order them and receives the results. We collaborate with pharma, and we are in discussions with HMOs to help do preventive type and life improvement interventions early on before people become very sick. And clinical trials, hopefully, will get more and more involved, so we don't have this sort of sad rate of failure where a lot of psychiatric drugs fail during the clinical trial development because there are no precise measures for testing who responds and who doesn't. So in the end, it's not just medications. So this is another cartoon from New Yorker where this gentleman goes to a sage on the top of a mountain, and the sage tells him medicate instead of meditate. A lot of patients come to me, I'm a psychopharmacologist, and actually tell them meditate, not just medicate. So, it takes a variety of approaches to have somebody do well, live a great life, and be able to contribute to their family, to society, and so on. And we should use all those. So we shouldn't sort of become fixated on a single approach. And I'd like to acknowledge my colleagues in the specific studies mentioned there. And this academic research work has received funding from the NIH, from the VA, in years past from NARSAD, which is now called something else, Brain Behavioral Research Foundation, and so on. And thank you very much for your attention, and I'll stop here.
Thank you, Dr. Niculescu.
Stop sharing. And I have, we have a few minutes for questions if you want. Happy to answer any questions. I might not know the answer, but take a shot if you want. I don't know what your usual sort of approach is. Do people ask questions? Do we have a Q&A or not?
Yes.
Go ahead. Okay, so let's go
I think
for it.
Chris wanted to ask a question.
Hi, Professor. Thank you. Thank you for doing exactly what we need as end users. I'm from Australia, and I note that you're saying that the blood testing is done only as a doctor initiated. Are you doing that service internationally?
We're trying to find ways to do that for people who live outside of the US. In the US, it's fairly straightforward. We have a sort of a central, very large lab organization that has partnered with us. So it's helping us do all the blood testing and so on. Internationally, we've been talking to some people in the UK where there's a partner lab that could do that for us. For the other parts of the world, I think we would need to find a local laboratory to do that. Alternatively, the other thing that the company is exploring is if there's sort of a streamlined way to ship actually samples across borders from they could be collected by your doctor in Australia or whatever part of the world that the patient is, and shipped to the US for testing. And then the report part is easy because that's all digital. We send the report digitally to your doctor. But at this point, we're still figuring all those things out. We're not a gigantic organization. We're still a sort of a relatively small startup. And we work flat out to roll this out because we know how much need there is and so on. And I personally, as a clinician and as an academic, I've seen this firsthand over a year, not just in my patients, but on the academic side. Each time we published a study, I would get all sorts of phone calls from patients, families, and so on, wanting to get tested. And then I would tell them, look, this was a research study. You cannot just come to my lab and get tested. Well, now finally we have a place where people can come and get tested, but we haven't completely figured out how to do the international bit for the molecular test, for the blood test. Now for the digital products, it's not an issue because digital is easy. You just go to the Apple store or Google store, download the app and so on. For the suicide prevention digital product, SX Prevent, the same thing is digital. So that one is prescription, but you can contact the company, and wherever in the world your psychologist or psychiatrist is, they can get it and they can use it with you, and you get sort of a personalized treatment plan, like lifestyle changes that you can do to decrease your risk of ever ending up in a suicidal state and so on. The molecular part, we have work to do to figure out how to roll it out internationally. So ask me again in a year.
There's a 20-year, you're getting there, and we're so grateful for that.
We're very perseverant. We never give up. We're slow. We're like that, the tortoise and the hare. So I've seen sort of many exciting things come and go in my field. We've always sort of like plodded along, kept at it, and we'll keep at it until this is widely available and can be directly useful to patients worldwide.
And the ISBD is saying that we're nowhere near getting precision medicine. So what you've just presented has given us a lot of hope. So thank you.
Thank you. I think a lot of people in the field are wedded to the previous approaches and the status quo, right? So, I'm in many ways, I came to brain health and to mental health from outside the field. My research work prior to switching to neuroscience was in cancer molecular genetics. So I have sort of I carry no baggage. I have no sort of, inhibitions about using the latest state-of-the-art things in psychiatry. There's no reason why mental health should be, 5, 10, 15 years behind other medical specialties, right? So, in cardiology, when you have chest pain, you don't just tell your doctor, I have chest pain, right? You tell them you have chest pain, but they also do an EKG and they do a blood test, right? To look at troponin, other enzymes, and so on. It's unconscionable that, in this day and age, we still sort of rely on subjective self-report. And it's not necessary anymore, we think. But, there is a sort of a tradition of pessimism and failure in the field that has made people maybe a little bit more, refractory to new things. I mean, when we've developed this, we've actually talked to colleagues in the field and said, would this be useful to you? And they said, no, I'm a great psychiatrist. I can just sort of look at somebody or talk to them and make the diagnosis. I don't need the blood test to tell me that. And I said, well, are you sure? I've been seeing, very complicated cases in a university setting for 2 decades, and I still sort of would love to have these tools in my clinic, to tell me which medications might work and so on. So there's sort of this provincialism and inertia and so on in the field that we need to address. And maybe it's a generational thing, like all these generations of younger doctors that I trained, residents and so on, that are now sort of becoming their own right professors and so on all over the country. They're much more high tech and they're much more inclined to use the latest and so on. Primary care doctors, your GPs are much more inclined to use those tests because they use them all the time, for your annual exam and so on. So, we'll keep at it until, it gets sort of widely used and so on.
I know others are going to have questions, but just one more thing that I had life experience with is I had my gut microbiome done, and I wasn't expecting that they actually do a neuropsych DNA as well. And they looked at tyrosine, tryptophan, histamine, and GABA, and my tyrosine was non-existent and my tryptophan was off the scale high. I took tyrosine supplements and it worked. So there's another biomarker that's never used, and I have no idea why my tryptophan was off the scale, but I can't take serotonergics. So that was a very interesting biomarker that hasn't been explored as yet.
Well, thanks for sharing that. I can tell you that this sort of the microbiome is a very sort of hot area right now. I used to be a little bit skeptical that you could sort of just, by looking at somebody's gut bacteria, make inferences about brain health. But the data has started to come along, so reproducible from multiple groups and so on over the last few years that I've become a believer. But we were speaking about conservatism, right? How some of our colleagues are conservative in regards to our test. So there you go. I shouldn't be speaking because I've been very conservative in regards to the microbiome. I felt it's like a black box, and we can, there are all these sort of like species of bacteria, and I don't see how it could work and so on. And it turns out that it probably does work. So good for you for doing that. Empirically, based on our work, we think doctors should be careful about using SSRIs in bipolars. Should not be using them in monotherapy, meaning by themselves, and maybe use them with a mood stabilizer, or don't use them because they can flip people into mania, agitate them, and so on, make states, including make them suicidal, like that poor lady that I was showing you data for.
Does that apply to SNRIs as well?
That's a very good question. The SNRIs also affect the serotonin transporter, right? That's half of what they do. So we're not entirely sure, but we recommend that in patients who do have bipolar disorder, or whose biomarker profile shows that they have a propensity to develop bipolar, even though their first episode is depression, that the mood stabilizer be in place first, and then you can add other things, so that you have that safety net and prevent things. So even for SNRIs, I think using a mood stabilizer first, or in addition to an antidepressant, an SNRI, is wise. So that's what we recommend. That's what I do in my patients. We've had a lot of surprises, pleasant surprises with lithium, which is a very old medication. It targets a lot of the markers that we find. We also found its fingerprint in molecules that are involved in brain health, in memory, in preventing Alzheimer. So low doses of lithium might be something that doctors should, again, revisit and reconsider. And our molecular tests support that. And I use it in my patients as well. So those are some of the sort of practical applications. In the old days, which are not so old, they're still being sort of practiced like that in certain places. So, the future is already here. It's just not evenly distributed. So the old days are still, conversely, the old days are still here in some places. People, my colleagues tended to use very high doses of medications, and then people will get side effects and abandon that medication completely, or use high doses because they were mitigating the side effect of another medication. So you end up on 4 or 5 different things at high doses with side effects. Simplifying things and so on, things that are rational, that work based on your biology, you can use very low doses. So our goal is to provide information that enables doctors to use the minimal effective doses of medication, so you get good effects, synergy between the medications without side effects. And that's what I do in my clinical population. That's what I teach my medical students and residents and fellows and young attending psychiatrists. Start with the lowest dose and build things rationally and find the minimal effective dose that works. Don't go sort of right, from the beginning, high doses, because you're going to get side effects. The patient won't take the medication. You lose that medication with them, and you'll have a breakup of the therapeutic alliance and their trust in you. And I think that's what happened to lithium in the past. It was these are very high doses where people get side effects, so then people didn't want to take lithium anymore. So
yeah, I had to stop taking lithium because it was causing a lot of side effects for me. But also, I know that my dosage was increased because of breakthrough episodes, that maybe it didn't need to have been kept at such a high level. I don't know.
Yeah, so it's worth a conversation with your doctors. Would a very low dose of lithium be useful to add to my regimen? Very low dose. And by low dose, I mean like 10 to 20% of the maximum dose that was used in the past. So I have people on, just to give you an example our practice here in the US, 150 milligrams of lithium a day, which is 10% of the 1,500. That's the recommended dose in, you know, in full-blown hospitalized bipolar patients. That's doses. There are no side effects. They can stay on it forever. It would probably protect them from developing Alzheimer down the road, helps with suicidality risk and so on. So we've become, based on empirical data and clinical practices, great believers in low dose lithium as an adjuvant to a lot of the things that we're doing in mood
What a
disorder.
great, if I learned nothing else today, that will help me a lot, because it was tremendously effective for me.
Revisit it at low doses. Talk to your doctor about that. That's what a lot of the patients who are referred to me. So nowadays, because of all these different things that I'm doing, I can see patients only 1 day a week because I'm wearing all these different hats. So I mostly see sort of complicated cases that are referred from colleagues across the, you know, the city, the state, sometimes from across the country. And I supervise younger doctors who are, learning their craft. And even in complicated cases, so these cases are people who end up on, you know, being tried, you know, the kitchen sink is thrown at them, right? They come with like, you know, 5, 6 different medications, some at loggerheads with each other, high doses, you know, and they're labeled as treatment resistant or refractory, and they're not. It's just they ended up in this sort of, with this accretion of different medications that are, irrational and create side effects, and use one medication to medicate the side effects of the other, and you end up with this sort of Tower of Babel of pharmacology, of poor pharmacology. So then we declutter, we simplify, and then they end up with a sort of clean medication regimen at low doses that works on them and so on. Now that we have MindX Sciences, hopefully some of those people can also get the molecular profile, so we don't just have to rely on our pattern recognition and clinical experience, but can have actually empirical molecular data to match them to the right medication. So I would end with that low dose lithium is something to consider, to discuss with your doctors. We've been another big surprise for us, omega-3 fatty acids. So a lot of our markers in different mental health disorders map to that pathway and normalize omega-3 fatty acids, normalize biomarkers involved in, voila.
Yeah. I have a question. What's the practical way to get this started, this process started? Because you've described my son on the treatment resistant, all the different meds. It's like he's just tried so many different things. Yeah. And so, I don't think that it's fine-tuned in the US. And also, what omega-3 fatty acids do you recommend? Does it matter?
So in terms of your son, we haven't done this work in adolescence, so I don't know.
22. He's 22.
Okay. And then in terms of the US, just go to the website MindX Sciences. His doctor should contact, the company, and then the company will, he'll have to sign up for the early access program, and then the company can send him a kit for the blood testing, and then the doctor prescribes it, and then your son can get the blood drawn and so on. So besides sort of the international issue, another limitation that we are fighting very hard, and again, ask me about this in a year, is that it's access to this, right? Because these tests are extremely expensive, and right now there is no coverage, Medicare or insurance or so on, to pay for them. So initially, the people who are getting them are people who are sort of paying out of pocket, basically. And we're putting together a mechanism in place. The company is where there's some sort of like installment plan, that sort of thing. So that bottom line is why I'm pushing them to, to find ways to ensure access to care. And it's not always easy. So the company has filed, for these so-called CPT codes, so that they can get, in a few months or a year, there'll be some Medicare reimbursement, talking to insurance companies and so on. But again, currently these tests are not reimbursed, and that is an issue. So hopefully
how
in a year,
expensive is extremely expensive?
That's something that sort of the company handles, but these are not So the company has, again, sort of at my prodding, priced them $1,000 less than the comparable test in cancer. So they're comparable tests in cancer that are being sort of that use sort of similar technology and so on, and those things are priced. We're talking here about thousands of dollars, right? So
like tens of thousands, 5,000.
No. I think it's a sort of the discussion that the company has with physicians, depending on the early access program and so on. Now, my understanding is the cancer companies charge about $2,000-3,000 for this test, $3,000, and I've urged the company to go $1,000 lower than that, so about a couple of thousand or less for these tests, and our goal is to have Medicare reimburse them, to have insurance companies
That's
reimburse.
still substantially cheaper than a lifetime of wrong treatment.
Well, it's
a one-off test, isn't it?
Right. I mean, in the US, it's cheaper than 1 day of hospitalization. So if you have the wrong diagnosis or you're not treated properly, you end up in the hospital for 5-7 days. 1 day of hospitalization is more expensive than the test. But the healthcare system is very fragmented. So until we get this sort of used widely, so it's used for prevention, and the insurance companies sort of see the value of that, how it saves them money. Because you can talk to them about, this saves lives, improves people's lives. I think what resonates with them is how does that save them money or makes money for them? So if you tell them that, look, you're covering a patient population, it reduces what you have to pay for their hospitalization and so on, because these people are doing better, don't end up in the hospital. A day of hospitalization is $2,000, something like that. Then you can start bringing them on board to start paying for this. So I'm learning all these things. It's a new world for me as well. But we're very perseverant. So we would like, for this to be widely accessible. So one way or another, we'll make it happen. It just might take a little bit of time to ensure access and everything.
Can I get Katrin to get me your email address? I'd like to connect the genetic pathology company in Australia, who is very proactive in this, on with what you guys are doing.
Yeah, so nowadays it's very simple. You can Google everybody. There's no privacy left.
Okay, thank you.
So just Google my name or Google the company, and then you'll see their website. There's a lot of information there, how to contact the company. And I think that's the best route. If you're thinking about that genetic testing company, they should contact Mindex Sciences, and we'll respond and everything. And then on the academic side, I don't sort of like always disclose my my academic email, because I would get sort of bombarded with and I don't mind, every patient message that I get, every family that calls me, I respond personally to all of them. But the issue is that sometimes those are HIPAA type issues. So then when people start emailing in an unsecured email things related to their privacy and mental health, then so that's why I tend to sort of not give that out publicly. But through the company, you can contact me anytime, and I'm sort of very diligent about responding to things. I take these issues very seriously. So.
And can I circle back to the question of the omega-3 too, just if you have something that you specifically recommend?
Yeah, so all my patients are on omega-3. They've been on it for years, unless they have a bleeding disorder, because the only sort of side effect of omega-3 fatty acids is if you have, they are like baby aspirin. They make your platelets, stick less, which is a good thing in most people, right? That's why people take baby aspirin. But if you have a bleeding disorder, that's an issue. So unless they have that, they are on it, on omega-3 fatty acids. And what I tell them is the key thing is, I can prescribe it for you. So it's a prescription medication. In fact, I remember a few years ago, I had to have battles with the hospital administration and the pharmacy to get it on formulary, and it's sort of very inexpensive, but they were getting all these sort of latest antipsychotics and so on that cost an arm and a leg, and it took me 2-3 years to get it on formulary so I can prescribe it to people. So I wouldn't just tell them, go to the vitamin section and get it. So, sometimes, even things that are, that should be, a no-brainer take time. But what I tell my patients, look, you can get it by prescription nowadays, or you can get it yourself. Just get the formulation that is mercury-free. Very important, mercury-free, because it's extracted from large fish. Some sources are large fish, some sources are small fish. The large fish have a lot of mercury, right? So get a formulation that's mercury purified. And, I tell them, take 1 or 2 capsules a day. This way it's a low dose, they have a safety margin, so they don't get, they don't start burping and then they stop taking it.
That's why my son stopped it. It's the fish burps. He couldn't stand it. And so stop taking it, won't take it now. But
yeah, take 1 or 2 a day. This way you don't burp so much. Another sort of trick that my patients taught me is they found that if you put it in a Ziploc bag in the freezer and it's frozen, and then you take it out, you have less of the odor, the aftertaste, and the burping.
okay.
I'm sharing that.
Thank you.
The important thing is mercury free. That's the key thing. And I think, everybody should be taking it for their health, unless they have a contraindication. Basically, our brain is made primarily of DHA in terms of fatty acids. DHA is one of the omega-3 fatty acids. So, it's crucial for synapses, for neuronal function, and so on. And our data, is very clear that these omega-3 fatty acids can help with many different types of mental health conditions. Specifically, they help with mood disorders. They normalize some of the markers. All right, I think we have to wrap up here, but if there's any last 1 or 2 questions, happy to answer them. So,
any thoughts on magnesium?
Yeah, so magnesium is also something that most of my patients are on. The evidence there actually comes from anxiety disorders. So some of our studies on anxiety disorders have shown that some of the molecular pathways and biomarkers that are involved in anxiety are, modulated by magnesium. Anxiety disorders are very comorbid with other disorders. So a lot of people with bipolar disorder or depression have comorbid anxiety. So again, low doses, so you don't have side effects, but most of my patients are on magnesium at night, low dose melatonin at night. So besides medications and meditation, they also take nutraceuticals. We try to tailor that for each patient, but omega-3 fatty acids are innocuous and good for most people. Magnesium at low dose is good for most people. Melatonin at low dose, again, low dose, not high dose. High dose might be activating people, but low dose can be used.
Thank you.
It's very useful in terms of regulating circadian rhythms, which, as I was telling you, are key to mood disorders.
Thank you so much. This has been a wonderful talk.
My pleasure, guys.
Thank you, Dr. Niculescu.
Keep up
Thank
the
you.
faith. We're doing our best. We're doing our best. And there are many other groups in the field that are doing their best to bring, precision medicine to mental health. And I think, the younger generation of doctors are much more, so thank you all.
Thank you.
You have a nice rest of the
Thank
day
you.
wherever you're at in the world.